Okay, number 3 in the ventilator basics series. This is the last one for this short little 3 video stint, but this is on ongoing ventilator management after you get them set up and after you've mitigated alarms. All right, when it comes to ongoing management, the first thing you always want to do is just be cognizant of alarms. So we just talked about alarms, so make sure you saw the previous video. It will be right next to this video in the playlist. You're looking for low VE or VTE alarms. You're looking for high VTE or VE alarms. You're looking for high pressure and low O2. Those are some of the biggest ones out there. Now that low VE, like we mentioned before, can be due to breath stacking, leak, low PC setting, pressure control setting, or dead space. So the other video explains this really well as the high VE, which is sedation or sensitivity issue. O2, make sure it's connected and on. And then, of course, the high pressure, juxtapose dope pneumonic versus P-plat, and that'll tell you which way to go. All right, let's go to the next one. With ongoing management, first thing we would also want to, or one of the first things is also to start managing oxygenation and make sure that we're good. We use an ABG or SpO2 to monitor that. We usually want our SpO2 between 94 and 99. We're going to titrate PEEP and FO2 to get our oxygen up. Okay, so we go up on PEEP and up on oxygen or FO2 to improve our oxygenation. Now, PEEP usually comes a little bit of a sacrifice, but it's usually not till about 10, 11, or 12 that you'll start anecdotally, but I mean, most of us agree about that level. You might get a little bit of drop in blood pressure. People that are really sick, you might see it drop a little earlier, but usually it's in the upper, 8, 9, 10, 11, 12, in that ballpark is when it'll start happening, and depending on where your patient is sick wise. You can also increase eye time, and that's really what you're doing with PEEP is you're kind of, it's sort of having a longer eye time through exhalation, but that's getting a little deep. But anyway, titrate PEEP, FO2, or eye time to increase your oxygenation. If it's 100, then reduce one of these things, right? Reduce PEEP or FO2 to get your 94 to 99, because if it's over 100, or if it's 100, then it could be spilling over more and more oxygen into your in your blood, into your plasma, and just that could be hyperoxic. That could cause damage. Want to make sure that we keep that in between 94 and 99. If it's less than 94, then we need to increase it. All right, let's ensure ventilation as well. This is the CO2. So again, we're going to use end-tidal CO2 or the ABG to monitor it. We titrate respiratory rate, tidal volume, and or pressure control if you're in pressure control to adjust this. Now, E-time I have there with an asterisk. It's an indirect measure. If you increase E-time, you're going to increase your exhalation. You're going to increase the output of CO2, but it's not like a very direct thing. You want to change rate, volume, tidal volume, or your pressure control setting to achieve that. So if it's less than 45 on a normal patient, the idea is you can increase respiratory rate, tidal volume, or pressure control. If it's less than 35, then you reduce your respiratory rate, your tidal volume, or your pressure control. That way that there's less times that's happening and your CO2 can build up. If your CO2 is too fast or too big, then you breathe faster or deeper so that you reduce the size of your end tidal. All right, now let's take a look to see acidic or non-acidic. So still on assuring ventilation, if they're normal, we just do what we just did on the previous page. Keep them somewhere between about 35 and 45. If they're acidic, then the idea is that you increase that VE. That's why in the initial setup that we gave a little bit more minute volume, a little bit more air to the patient that's sick, because they're probably a little acidic. And if they are, then we need to get rid of a little bit more than normal air, therefore getting rid of a little bit more normal acid, and therefore we protect their pH. Mid-20s end tidal is a great starting point if you don't know what they were moving before. This protects their pH. The idea of match their rate is only part of the equation, because rate times volume gets minute volume, and minute volume is really what's changing your pH. So if they're breathing 30 times a minute, they match their rate. It's not really their rate that is really helping, is that you really want to match. You really want to match the minute volume. So, but we really can't measure the output of the tidal volume until they're on the vent. So it gets kind of confusing. So the cool thing is end tidal is really your target, really your PCO2. If you get those around low 30s, upper 20s, maybe mid 20s, then you're basically instituting a respiratory alkalosis to combat whatever metabolic acidosis that's present. And the idea is that they start kind of helping one another out and bringing your pH up closer to normal. If you put somebody that's acidic on 12 and 500, you could kill them, right? And maybe not directly, but you're putting the nail in the coffin a little bit later down the way. What we do in 30 seconds, will help what we will do in 30 minutes, as so says the sepsis studies right now, will begin to improve or decline. And so these little things are going to go a long way. I know this is a long video, but very important. The only thing I think I haven't mentioned is like, okay, what if you have a head injury patient, you have a neuro patient, where do you kind of park that? A lot of the research and studies right now say about 35, right? Some will say a little bit go to 30, but in the end, like if you're at the lower end of 35 with vasoconstriction, that's a safer bet. So a 35 end tidal is usually my target. A little bit above, a little bit below, I'm okay with, but I'm trying to target towards that lower side of normal. And if I go a little bit toward 30, I'm okay. But that's the idea if they have a neurologic insult. So anyway, hope you enjoyed it.